We've seen that Americans care deeply about global health. We've seen that the United States is involved across a wide range of organizations in the global health scene and participates in many international initiatives. We've seen that we are the largest single funder of health assistance to the middle and lower income countries to help them improve their health conditions. We've also seen that even as the largest funder, our level of effort as a share of our national economy is not as large as some other countries. And we've seen reasons why Americans care about global health that don't have to do only with their concern about others in the world, but have to do with their concern about their own health and well-being and the threats that they may face from outside. But the U.S. is not always an entirely positive actor in the global health scene, and it's important to be open and acknowledge some of the things we do in global health that are driven more by our own self-interest and domestic concerns, which may not contribute constructively to improving health worldwide. I've talked a lot about U.S. aid to lower and middle income countries, but if we look at the volume of aid going to specific countries, as we do in this chart, we can actually see that 4 of the top aid recipients from the United States in health actually represent countries that may not have the largest health burdens or health needs, but really reflect more the national security concerns and interests of the United States. For example, countries like Afghanistan and Iraq are countries that receive a large amount of U.S. aid. Indeed, they do have important health needs, but they also receive this aid because they are part of larger U.S. national security arrangements. If we were to allocate our health aid purely according to health need, we might see a very different set of priorities than the ones we see in this chart. The United States is also an important force in the global health economy. One example of this is the strong attractive power we exert over health professionals from other countries in the world. In this chart, we look at a problem called medical brain drain. And that is the migration of nurses, and in the next chart of physicians, out of their home countries to seek employment in countries where their career prospects may be better, their income and remuneration opportunities better, and they often come to the United States for these reasons and do not return to work in their countries of origin. In the United States, in terms of our registered nurse workforce, we currently have about 2.2 million nurses working in the United States, and there's a shortage of nurses, a significant shortage of nurses, more than 10% of this amount. Currently, about 4% of the nurses in the United States are foreign-born who have emigrated to the United States in order to work here and improve their own personal prospects. This results, some feel, in a shortage of nurses where they may be needed more for health purposes, and that is in the middle and lower income countries where they were born and where many of them were trained, often at public expense. A similar situation exists for physicians. International medical graduates today constitute about 25% of the physician workforce in the United States, and 60% of those come from low-income countries. These are often people who've been trained at public expense in medical schools, highly costly training, scarce training in their countries, who then, after graduation, get the opportunity to migrate to the United States and serve American patients. This is a real cost to the countries from which they come and a real benefit to us. As I mentioned earlier, there are a number of international agreements and treaties that have been developed in recent years. The World Health Organization is often the focus for the development of these agreements and treaties. But when we look at many of these treaties, we find that while the United States participates in these international organizations and is part of these discussions, we often fail to ratify these international treaties in contradiction to the experience of many other countries which may ratify these treaties. This is a list of the treaties and protocols not ratified by the U.S., which are very widely recognized and approved in other countries. Some of them may shock you. The Convention on the Rights of the Child, the Kyoto Protocol on Climate Change, the WHO Framework Convention on Tobacco Control, the Protocol on Water and Health. Many of these things recognize rights and requirements of meeting basic health and welfare needs in lower and middle income countries, which many countries of the world have committed to internationally, but the U.S., because of our domestic legislative processes, has so far not ratified or agreed to. So we are not always a supporter of global agreements that are seeking to make progress on improving health and well-being worldwide. Our domestic political process has other consequences for our role in the world and our health assistance. In the 1980s, the United States supported something that we call domestically the Mexico City policy, because this was put forward by former President Ronald Reagan at the International Conference on Population and Development in Mexico City, that forbids U.S. government support to non-governmental organizations which provide information about abortion or abortion services outside the United States. This Mexico City policy also limited our assistance for certain kinds of family planning. The policy was put in place by former President Ronald Reagan and was supported by Presidents Bush, both younger and older, but it was voided by Democratic presidents who came in between the terms of these presidents, including both President Clinton and President Obama. And this Mexico City policy had a serious effect on the financing and support for many important international programs, including many of those that were run by the UN Fund for Population Activities, UNFPA. In the early years of the HIV/AIDS epidemic, we also had strong policies requiring recipients of U.S. government assistance to emphasize abstinence in addressing HIV/AIDS control and to advocate strongly for abstinence or abstinence-only programs as part of their HIV/AIDS programming work. This policy of advocating abstinence often flew in the face of evidence which suggested that the most important contributions would be those related to changing the behavior of people who are already sexually active. Another set of policies related to sex workers. In the United States, sex workers are very much a part of the spread of the HIV/AIDS epidemic, which has been documented in many studies throughout the world. Addressing HIV/AIDS prevention measures through outreach to sex workers, improving sex workers' position to be able to advocate for things like condom use and other HIV/AIDS prevention measures is an important part of AIDS prevention and control measures around the world. In the early years of PEPFAR, funding was tied again to strict pledges on the part of recipient agencies that they would not do anything that could be construed to be advocating in favor of measures to improve the lot of sex workers. This prevented us from funding education and support for the most vulnerable sex workers. In 2013, many years later, this provision was struck down by the U.S. Supreme Court. In its economic activities, the U.S. also is strongly involved in many things that are not good for our own health or for global health. Tobacco is one of the most dramatic of these. We're the third largest producer of cigarettes in the world, almost 340 billion cigarettes in 2010, and the fourth largest exporter of cigarettes. In our engagement with global trade negotiations, such as those with the World Trade Organizations, we have been strong advocates to accelerate imports on cigarettes and lower tariffs. And as I mentioned earlier, we haven't signed the Global Framework Convention on Tobacco Control. It's also been said that the U.S. food industry is a major exporter of food products and also proponent of eating habits and dietary changes which are significantly responsible for the exploding epidemics in diabetes and heart disease that we see in developing countries. Of course, we also subscribe to these same food products and habits in our own country. Olivier de Schutter who is the UN Special Rapporteur on the right to food, has said that the West is now exporting diabetes and heart disease to developing countries, along with the processed foods that line the shelves of global supermarkets. By 2030, more than 5 million people will die each year before the age of 60 from non-communicable diseases linked to diets. And Mr. Deschutes believes that the U.S. food industry is an important part of this process. As we've seen earlier, the U.S. is an important, a very large player in the global economy, and we play an outsized role in global trade negotiations and trade arrangements. We're a very active member in the World Trade Organization, which has had which has dealt with a number of issues which have important implications for health. Perhaps one of the most important has been around intellectual property rights, and particularly those that relate to pharmaceuticals. In the HIV/AIDS era, the development of antiretroviral treatment highlighted this important issue and created some very strong conflicts between those who were supporting the intellectual property rights of patent owners and holders to antiretroviral drugs and those who were supporting accelerating the access to these life-saving drugs for poor populations who could never afford to pay for these drugs at international prices. The U.S. often found itself on the side of those defending the intellectual property rights of the patent holders of these antiretroviral drugs and being opposed by public interest groups in the United States and in other countries who wanted to activate special WTO provisions which allowed countries to violate patent protections in cases of public health emergency. And this is an area where the U.S. really did not support at all or strongly the rights of people to gain access to these life-saving drugs. Fortunately, international programs were successful in getting around these U.S. positions and dramatically expanding access to antiretroviral drugs, much of which was also financed by the United States through international organizations. Similarly, as I mentioned earlier, we've also strongly supported the efforts to limit restrictions on tobacco imports to defend our tobacco trade interests. A last important observation about the U.S. role in the global scene that might have negative health effects concerns the impending global climate change crisis, which many feel is already well underway. The U.S. and China are the leading causes of world carbon emissions. Only recently has China's emission of carbon equaled that of the United States. But for many years, the United States overwhelmingly was the largest emitter of these climate-damaging chemicals and some feel is the major source to date of the negative effects on climate that are about to inundate our world. So not only in terms of direct health activities do we sometimes find ourselves on the wrong side of policies and programs to improve global health, but also even on new and emerging and wider-ranging issues like climate change. The U.S. may have a lot of reasons to question its behavior in the global scene.